Hello, everyone. I am State Representative Deanne Mazzochi. Tonight, we are discussing an elusive disease that is sadly all too common. It's called spondyloarthritis. It's a part of a family of inflammatory rheumatic diseases that manifests itself as inflammation, stiffness in the spine and pelvic joints, which can cause joint and back pain. One of the issues with spondyloarthritis is that it's actually very difficult to diagnose. But early diagnosis is one of the things that's absolutely critical when it comes to preventing further long-term disabilities. One of the things that we've learned is that frequently women and people of color, they can go from doctor to doctor before somebody finally makes a correct diagnosis. And unfortunately, because of this name, maybe because it's so hard to pronounce, over 3 million individuals suffer from this disease across the United States. But unfortunately, it actually gets less attention than other diseases that are more well known, such as MS. That's one of the reasons why I was very glad to pass House Resolution 828, which is declaring May Spondyloarthritis Month here in Illinois, and to also host this webinar to help raise awareness of the disease, its treatments, and particularly to introduce you to our expert panel members tonight who hopefully can help. So tonight, our speakers in order, first is going to be Haley Burge Christensen. Despite a family history of the disease, she experienced years of misdiagnosis, but finally was able to find the right doctor to get relief for her symptoms. Also joining us tonight is Dr. Nisha DeSilva. She is a rheumatologist who is well aware of and has helped to treat spondyloarthritis in many of her patients. She is also a professor at Midwest University here in Downers Grove. We are also very pleased tonight to be joined by Dr. Ashraf Darwish. Dr. Darwish is a renowned orthopedic surgeon who specializes in issues affecting the back. And he's going to be able to give us some guidance today on what to watch for when you have symptoms involving your spine and back, and typical treatment options there as well. So thank you, everybody. Welcome. And thank you to all of our attendees who are joining us. We do want to let everyone know that if you have questions, you can put those in the chat box. If you're joining us through Facebook Live, you can also put questions down in the comments, and our host tonight is going to make sure that those questions get captured, reported, and forwarded on to us so that we can hopefully answer them as soon as we can at the end of the panel presentations. We do expect that we're going to be done roughly around 8 o'clock. So hopefully you'll be able to sit with us for the next hour and learn some useful information for you, family members, friends, or others in your community who are suffering from these types of symptoms in the disease. So Haley, let me turn the floor over to you to talk about how you first found out that you had this condition, what led up to it, and a little bit about your treatment journey.
Great. Thank you so much, Representative Mazzochi. I first want to thank you for doing this and passing this resolution. I reached out to her, and to my knowledge, she does not have any personal connection to the disease. So for her to listen to a member of community and advocate for members of her community on our behalf is really special. It's supposed to be what elected leaders do, and I really appreciate that. So I wanted to share some statistics I know Representative Mazzochi already has, just to put my story into perspective a little bit. As she stated, ankylosing spondylitis, which is the disease that I have, is actually more common than rheumatoid arthritis, ALS, and MS combined. Yet I'm sure if you told anyone that you had ankylosing spondylitis or a friend with the disease, they would first say, "What's that?" and second, ask how to spell it. So that's happened to me several times. As Representative Mazzochi stated, there is a major diagnostic delay when it comes to this disease compared to others. Specifically, there's a major diagnostic delay for women as well as men, but the diagnostic delay, the median is 9 to 14 years. For males, it's 5 to 7 years. Being diagnosed as soon as possible, because this is a painful chronic pain disease, as well as a form of arthritis that attacks the spine and can lead to progression and permanent irreversible damage, is very important. So I think having awareness about the disease and understanding what to look for is very important. Prior to the last few decades, they used to think it was primarily a man's disease. Now, recent studies have showed that the ratio is 3 to 1, or even as close as 1 to 1. So it can affect women just as much as it can affect men. So a little story about me. My grandmother, as well as my father, both have ankylosing spondylitis. It typically runs in families, and typically families with ankylosing spondylitis, not always, but typically have a gene that's HLA-B27 gene. So me and my father, as well as my grandmother, have that gene, but finding out that I had that gene and that this was what was wrong with me took quite a bit of time. So my first experiences with lower back pain and stiffness were as early as high school. So I'm 31 now, so a long time ago. And originally, when I came to my doctor and told them about experiencing pain and stiffness specifically in the morning, which is actually fairly common for ankylosing spondylitis, they said, oh, it's probably because I was a competitive lacrosse player, or perhaps it was menstrual pain, because I would have an increase in pain, specifically back pain during menstruation. Actually, that's fairly common in women who have ankylosing spondylitis because hormones affect our pain levels. But it took quite a long time for me to get diagnosed. I went on and off with lower back pain, wasn't really finding answers, thought it was mechanical pain. Maybe it was just me getting older. Maybe it was lacrosse. Maybe this is normal menstrual cramps. And it wasn't until a few years ago that it got really bad. So starting in spring of 2020, around the pandemic, actually, so great timing, I started to experience more severe back pain that affected my daily quality of life. It became really hard for me to do anything that required me to sit still for long periods of time. So unlike other forms of arthritis, where typically, and other forms of back pain, actually, I'm sure the doctors can weigh in on this as well, but I believe it usually feels better with rest. But for me, I always felt better with movement. So when I was moving and exercising, I felt my best. Despite this and my family history, doctors still thought it was perhaps mechanical pain. And so I kind of just went through it and did the best I could to get through law school while dealing with this pain, even though law school requires a lot of sitting and studying in one place. So then this past summer, while I was taking the bar and getting ready for my wedding, my back pain started to spread to my thoracic spine, so the middle part of your spine. And it became so severe shortly after my wedding that I couldn't sleep at night for more than 2 or 3 hours without the pain waking me up, and it was difficult for me to breathe. So this is something that I hadn't experienced before, and I knew it was getting worse and worse. So I went to my doctors and they tested me for everything under the sun, GI issues, cancer was thrown in the mix for a second. And then I brought up to one of my doctors, I said, you know, my grandmother and my dad both have ankylosing spondylitis. I Googled it and it seems like some of these symptoms I'm experiencing sound like it. And my doctor's like, oh no, I don't think you have ankylosing spondylitis. And I'm like, well, maybe we should just test me for the gene and see what we find out. So unfortunately, I was right. And I did test positive for the HLA-B27 gene, and I was diagnosed with ankylosing spondylitis this past fall. But while I was trying to await diagnosis and figure out what was wrong with me, I was again not sleeping for more than 1 or 2 hours a night and finding it difficult to breathe in deeply or really function at all. So I turned to the internet to try to find solutions. And I came across some medical research articles that talked about the gut microbiome and ankylosing spondylitis, specifically that those of us who have ankylosing spondylitis and the HLA-B27 gene, if you stop feeding yourself starch, it basically starves a type of gut bacteria called Klebsiella pneumoniae, and it can decrease your symptoms. So at that point, I was very desperate for answers and to try to get some relief. So I cut out starch entirely from my diet. And before I started the diet, my CRP levels, which is C-reactive protein for those who are listening and don't know, so it's an inflammatory marker, were 15, which is extremely high. And then after going on the diet and going on Celebrex, which is an NSAID, my CRP levels went down from 15 to 2 within the matter of 6 weeks. So I consider myself very lucky. There's a lot of treatment options that I'm sure are going to be discussed, like biologic drugs, which are common for those of us who are suffering from ankylosing spondylitis. But I think anything that you can do to decrease the amount of inflammation in your body, whether it's pharmaceutically or through dietary changes, exercise, as I mentioned, has helped me and has been shown to help a lot of people with ankylosing spondylitis. Movement is truly medicine for us. And I know it's helped my father as well, but that will stop, at least my understanding of the drug, will help slow down the progression. So there's different forms of ankylosing spondylitis as well. There's non-radiographical and radiographical. Unfortunately, my grandmother was, I would say, fairly disabled starting in her late 30s, unable to take care of her children, and got progressively worse as she aged and was completely immobilized in a wheelchair for most of her life. My dad, however, has non-radiographic ankylosing spondylitis, which means he has very little permanent spinal damage in his spine and joints, which obviously I prefer to be more like my dad in this situation. But it's a little bit hard to tell, at least from my understanding and conversations with my medical team. So I think the important things to take away from this conversation is really listen to yourself and be an advocate for yourself when it comes to this. Again, it's a very underrepresented, underdiagnosed, misdiagnosed disease. And I think those with a family history especially should make sure that their medical team is aware of the family history. And then doing all that you can on your own and researching ways to decrease your inflammation in your body is really the key for this. My pain levels, I would say, we're probably at an 8 to 10 out of 10. And now I'm living every day with just a 1 to 3 pain level that fluctuates very little just on diet and NSAIDs alone. Again, it doesn't work for everyone, but I consider myself lucky, all things considered, and I think educating yourself is really important. So I'll turn it over now to Dr. DeSilva to talk about treatment options.
Thank you so much. And I think we have some slides as well from Dr. DeSilva. So hopefully we'll be able to get those up so that we can share them with the group and with some of our participants. Thank you so much, Haley, for sharing your story. It was really fantastic. All right. So Dr. DeSilva, as a rheumatologist, if you could talk about some of your experiences when it comes to diagnosing the disease, what it takes for patients to get to you, to find you, what they should be looking out for in treatment options, that would be fantastic. Thanks so much.
Of course. Yeah. Thank you so much for having me. And Haley, thank you for sharing your personal story. I hear that, unfortunately, time and time again about patients kind of suffering for years and symptoms, unfortunately, initially getting kind of brushed under the rug, and particularly young women. So you touched base on a lot of things that I was going to talk about. So I'll kind of go through some of those a little bit more quickly since you touched base on it. And so I am a rheumatologist, so I treat ankylosing spondylitis, and that is one of many spondyloarthropathies that we consider that are under that kind of umbrella term of HLA-B27 disease. If you want to actually put the slides in full view, and then yeah, okay, so like I said, so AS, or ankylosing spondylitis, is just one of them. Also on this spectrum of diseases are psoriatic arthritis, reactive arthritis, which is formerly known as Reiter syndrome, which tends to be post-infectious. So after patients have some sort of infection, as the body is healing after that infection, the immune system kind of wreaks havoc and starts to attack and have very similar symptoms of ankylosing spondylitis. There's also a group that's called enteropathic arthritis, which is typically associated with your inflammatory bowel diseases, so ulcerative colitis as well as Crohn's. But with all of these being kind of under one umbrella, you can have a lot of similar symptoms between these diseases, but each one might have one feature that's a little bit different than the other. If you want to move on to the next slide. So like Haley had mentioned, in about 80 to 95% of patients with ankylosing spondylitis, they have this gene, this HLA-B27. So classically in a patient with a genetic predisposition, there's some sort of trigger on the immune system that kind of turns that light switch from being off to on. Just because the gene is positive does not equate to having the disease, but in the right clinical scenario, like Haley had with the inflammatory back pain and some of the other things that were going on, that can definitely help lead to the diagnosis. Even just having a family history, sometimes patients don't know if they've had that HLA-B27 in their parents and siblings or grandparents or aunts, uncles, but knowing just that they had similar diseases might clue your doctor or clinician to want to work you up based off of the symptoms. Smoking has been linked lately to a lot of autoimmune diseases, and not only autoimmune diseases, but the just risk of inflammation in general. And this is not just for ankylosing spondylitis or our spondyloarthropathies, but also in rheumatoid arthritis as well as lupus. I'm not sure if my slides are still up, but another thing is that dysbiosis or that gut microbiome, like Haley had alluded to. So there has been a lot of studies now and a lot more research going into how the good bacteria versus the bad bacteria in the gut can predispose to autoimmune diseases and inflammation in general. So it is really important to try to adjust lifestyle and making sure that you're not smoking, alcohol is pro-inflammatory, sugar is pro-inflammatory, and trying to do what you can, especially if there is that family history. Next slide, please. So who gets it? So it's thought that specifically, at least for ankylosing spondylitis, that symptoms actually begin in patients' teenage years and 20s, just like Haley. But a lot of times it gets brushed under the rug because of athletes, because of injuries, car accidents, as well as menstrual symptoms in females. So that leads to my second bullet point, that in some of the more antiquated data, it suggests that it affects males more than females, but now it is seeming to be more a 1-to-1 ratio, where now that there's more awareness, a lot of females with this disease are getting diagnosed sooner and earlier. We already touched base about the hereditary predisposition. So knowing that there's a family history, it should be kind of in the front of your mind that, hey, if I have family members with these symptoms or similar symptoms, I might be at risk of the disease as well. So kind of also being your own patient advocate like Haley was is really important. Next slide, please. So in terms of what the symptoms are, and Haley kind of mentioned a little bit of it, it tends to be chronic pain and stiffness itself. And this typically happens in the spine. It normally happens in the lower back first, and then can progress higher up in the spine, like the mid back or the thoracic spine, and even the neck itself too. Like she mentioned, it's typically pain that feels better with activity. So normally when patients have like a herniated disc or other more wear and tear or degenerative changes, that pain gets worse with activity. The more you do, the more painful it can be, especially if you're not doing things properly. But with spondyloarthritis, you tend to have stiffness in the morning that can last for hours, and then it can actually come back even during the day. So if you have a more sedentary lifestyle, sitting on the couch for hours, then when you first try to get up and stand up, that stiffness is going to come back, especially if you're in the car. Even 20 minutes of being in the car can cause some of that stiffness. Now, keep in mind, some stiffness can happen even when you have regular arthritis, not necessarily this inflammatory autoimmune type of arthritis, but it's key that it does get better with activity and it does worsen when you're resting. That morning stiffness is key. It's also known as like a gelling phenomenon where kind of the synovial fluid kind of gets a little thicker. And then as you start moving, it's kind of like putting oil to your joints, right? So you're starting to get the blood flowing and getting some of those stiffness to kind of be worked out. I put in here, this is kind of a technical term, but there's also enthesitis, which is inflammation on more where tendons or ligaments insert into the bone itself. So this is where patients can get maybe plantar fasciitis, Achilles tendon discomfort or pain or inflammation, as well as other areas where there's tendons. So a lot of times, even the small tendons and muscles between the ribs itself can cause irritation. That's called costochondritis, tennis elbow, kind of things like that, especially in the setting of other symptoms. It can be a sign of maybe one of these spondyloarthritis. Next slide, please. And so that enthesitis kind of leads to my next, this slide, which is talking about how even though the term spondyloarthritis really means arthritis of the spine itself, these diseases don't just affect the spine. So you can actually get inflammation of the eyes, which is called uveitis. This is typically going to be very painful eye movements. You can get redness to the eye. The pupil can actually look irregular. It's not a nice circle. It requires steroid intervention for treatment. You can get inflammation of the aortic valve, which is one of the valves of the heart. In some of the cases, you can get inflammation of the skin, particularly with psoriasis. So patients with skin psoriasis are actually at risk of inflammatory joint pain as well as back pain. Some patients can even get intestinal inflammation. It does not need to be as bad as Crohn's disease or ulcerative colitis, but it can be just gut, like abdominal pain, diarrhea, maybe blood in the stools. So having those symptoms in the setting of back pain is definitely sort of red flags that should cue you or a family member to get evaluated. One of the complications from the disease is actually osteoporosis. So even though with the disease, you're at risk of the bone sort of fusing, it's not healthy bone. It's fragile bone that ends up becoming fused. And so these patients are at risk of osteoporosis where the bones are weaker and actually more at risk of fracture. Next slide, please. So how do you get diagnosed? A lot of times it's really just based off of history and a physical exam, especially if the provider is understanding of what the disease is and you have the family history. So asking about the morning stiffness, examining you and seeing and, being able to palpate, is there inflammation in some of the peripheral joints? Do you have tenderness of the spine itself or the sacroiliac joints, which are the kind of at the base of the spine? You can do blood testing where you're checking for that gene marker. You can check the inflammatory markers. Like Haley had mentioned, her C-reactive protein was elevated, as well as a sedimentation rate or a SED rate. You can check other blood tests to rule out other diseases. Like she mentioned, they were, doing a GI workup, even potentially cancer workup. So making sure that other diseases are also being ruled out. The main thing is really doing radiographs or imaging. So checking x-rays, particularly of the SI joints or those sacroiliac joints, looking for sacroiliitis or inflammation there. And even if the SI joints are negative, if I have a high suspicion of the disease, we'll move forward with that MRI to pick up that early disease or what Haley had mentioned, that non-radiographic spondyloarthritis. So that's when the x-rays are negative, but the MRI is actually showing potentially early inflammation and early disease. That is actually the best time to start treatment because it's before there's already permanent damage that's shown on the x-rays itself. Next slide, please. So I just included this case. This is a patient of mine. She is actually very similar to Haley, where she had symptoms in her, I think she was starting having these symptoms in 16, 17. She has a strong family history, multiple family members with various types of HLA-B27 disease, including ankylosing spondylitis and ulcerative colitis. And you can see kind of on the left side, though, these are the sacroiliac joints kind of on the side there, and they look actually relatively normal. But if you look at the screen on the right, this is just a snapshot of her MRI, and you can see, I don't know if you can see my arrow or not, but there is some SI joint inflammation or bone marrow edema. That's the bright white kind of at the base of that joint there that we were able to diagnose her. And she actually ended up being HLA-B27 positive as well. So this is just a case where it shows that importance of, even if the X-ray is negative, it does not mean that the disease is not still present. It just means that there's not permanent damage already done from the disease. Next slide, please. And this is another patient who's in her 30s. This is a little bit harder to see, but you can see this is her cervical spine or the neck here. And she has kind of some of these bridging syndesmophytes or kind of already fusion of her neck in the upper area as well as the lower spine here. So her neck is essentially already fused and she has very limited range of motion. So while you and I might be able to look over our shoulders, her range of motion is limited to this. And that's because by the time she was diagnosed, she already had this fusion. Again, a lot of her symptoms were brushed under the rug and thought to be due to posture, due to working in front of a computer, and all of these other reasons, when unfortunately it was ankylosing spondylitis. Next slide, please. Now, this is just a slide to show about psoriasis. A lot of times patients can be misdiagnosed as eczema, but you can see kind of plaque psoriasis in the upper left-hand corner, and the bottom left is showing kind of more that guttate psoriasis. And you can also have involvement of the nails. When you get nail involvement, it's thought that you're more at risk of joint involvement, particularly of the hands and those knuckles that are closest to the nails. So there's what we call nail pitting in that bottom right, and just kind of psoriasis of the nails in the top right. Next slide. Now, treatment, the main thing is going to be making sure that movement is medicine. Like Haley said, I love that expression, because physical therapy, occupational therapy is going to be important. You need to kind of learn how to not make pain worse as well, and kind of learn how to stretch and keep your stretching and exercising as almost like a pill that you have to take every morning. You need to keep that, and that's a huge part of your treatment to try to help prevent further damage and to make sure that you're keeping as mobile as possible. There are plenty of medication interventions. Like Haley mentioned, non-steroidal anti-inflammatories are an option and are an actually first-line therapy for early disease. In certain clinical scenarios, you might benefit from oral or injectable steroids. Again, that's more of a temporary measure. Ideally, you're not on the steroids long-term, but some patients with severe disease do require long-term steroids. The next step are what we call disease-modifying anti-rheumatic drugs, or DMARDs. I know it's a mouthful, but these are medications like methotrexate and sulfasalazine. Now, they don't necessarily affect the spine itself and prevent from the spine inflammation from progressing, but it can help with some of the other involvement, like we talked about with the skin, the other joints, those tendon inflammation that can happen. That's where there's a role in that. And then we have the biologics. So biologics, once you have true inflammation of the spine, the biologics are really the only medicine that has been shown to prevent further damage from happening, as well as treating the actual inflammation that's present. Now, remember, spondyloarthritis is different than degenerative disc disease or wear and tear. This is where your immune system is actually attacking and causing the inflammation itself. So how we target it is targeting the immune system. Now, these biologics have a whole slew of side effects, but again, it's at risk and benefit. Are we helping and preventing the disease from worsening? Are we treating the actual inflammation and hopefully extending life without major disability and immobility? Then that might be the risk that needs to be taken. There are surgical options, and I'll leave that to Dr. Darwesh, who's going to be talking next. Lifestyle changes, again, diet is huge. Trying to lead an anti-inflammatory lifestyle is as best as you can. So cutting out things that are going to be pro-inflammatory, like sugar, like alcohol, like smoking, making sure you're doing what you can for your gut, whether that's probiotics, prebiotics, all of these things are important. Trying to maintain a healthy weight is really important. There's a lot of studies that show that patients with metabolic syndrome, or patients who are overweight, that have high blood pressure, high cholesterol, diabetes, all of that feeds into that active inflammation and can make disease harder to treat and harder to get under control. So it's very important that it's not just medication. I can give you 4 or 5 different medications, but if you're not making those lifestyle changes, it's just going to be an uphill battle, and it's going to be hard to get the disease under control. It's also very important to find support groups and other people that you can talk to. It is hard because this is a lifelong disease. It's not something that you'll take one pill or you can get it just surgically removed and then it's gone forever, right? It's going to be a disease that you live with for the rest of your life. And the hope is that it does go into remission. But it's always nice to be able to share your story with others and kind of go through, dealing with that pain. Unfortunately, like Haley said, her pain was worse before, and now she's living with like a 1 or 2 or 3, I think you said, out of 10 pain, but that's still pain that she has to deal with on a daily basis. And sometimes it gets frustrating and aggravating having to deal with this, with these diseases. So it's nice to know that there's other people out there going through it that you can share, your story with and kind of offload to each other, right? All right, next slide, please. So I just included a couple links for those who want to get more information. So the American College of Rheumatology, the Arthritis Foundation, as well as the Spondylitis Association of America have these sites that are available that have a bunch of information. There's information on support groups as well. These are just some great resources for those who want more detail. Otherwise, thank you so much for your time, everybody. And thank you so much, Representative, for putting this together. This is such a great event. I really appreciate being able to participate. Thank you.
Well, thank you so much. We obviously appreciate your expertise, and while you've been able to give us some of the expertise on the the basic treatment side, I'd now like to turn the floor over to Dr. Ashraf Darwish, who is going to talk about, and Doctor, if you could talk about some of your treatment options and how you look at this disease from a surgeon's perspective. Thanks so much.
Thank you, and thank you for inviting me. I see a lot of patients, and my practice is in Hinsdale, Illinois, and I 100% of my practice is adult spine surgery. So I see patients from the age of 18 and on with spine conditions, and most patients who present to my office are there with either neck pain or low back pain, with or without numbness, tingling, weakness in their extremities as a result of some spine condition. Now, I'm in a huge orthopedic group, so I get referrals from the community as well as from the total joint surgeons, the sports orthopedic surgeons, the hand surgeons of their patients with low back pain. And although my title is a orthopedic spine surgeon, the vast majority of my practice is non-surgical. It sort of serves as a gatekeeper, as sort of seeing patients with spine conditions or with back pain, let's say, or neck pain, and making an appropriate diagnosis and guiding them in their treatment alternatives. The majority of spine conditions are successfully treated with non-operative care. And the non-operative care is usually an anti-inflammatory medication, physical therapy, activity modification, meaning either rest in some cases, or in the case of ankylosing spondylitis, it's actually activity, more physical activity. And sort of talking to patients and letting them know that their condition has the natural history of their condition, that there's sort of an endpoint. The patients I see in my office with 10 out of 10 pain, it's sort of the end of the world for them. They feel like this is, I've been in pain for 2 weeks. I've been waiting to see you for 2 weeks. I'm in severe pain. and this is never going to go away. My job is to make an accurate diagnosis so that I can guide them and let them know what that natural history is. Is this a real problem? Is this some tumor that's going to really change their life that we have to resect and chemotherapy and radiation therapy? Or is this just a muscle problem? Did you just sprain or strain your neck and your back, and you just need a good muscle relaxant, a good anti-inflammatory medication, a note to be off of work or off of school for a few days, and it's going to pass? Or it's something in the middle. Maybe it's a disc herniation. Maybe it's arthritic changes in the lumbar spine or the neck. Now, with ankylosing spondylitis, it's sort of difficult to make that diagnosis because the majority of the patients that we see are young patients who present to me, the ones with ankylosing spondylitis, present to me really with sacroiliac joint pain. That's the most common presenting symptom of the patients that I see who end up being successfully diagnosed with ankylosing spondylitis. They just have good old-fashioned back pain, and it sort of mimics every other patient who we see with SI joint pain or back pain. Now, as an orthopedic spine surgeon, we're very subspecialized. We're looking for big problems and surgical problems. And when we see a patient like Haley, who's a young lady who is presenting with maybe she sees me with a month or 2 months of back pain, it's easy for me or for somebody like me to say, well, Haley just has back pain. And the second most common reason that patients visit a physician or a PA or a nurse practitioner is for back pain. The number one reason is an upper respiratory tract infection or a cold or something of that sort. So it's very common for a young patient, to see a doctor for back pain. So it's easy for us to say, well, this is just back pain. And I looked at your x-rays, and your x-rays are fine. You haven't developed a bamboo spine. You don't have any signs of arthritic changes in your back. Your MRI, again, it's early on in the ankylosing spondylitis. Your MRI looks normal. So I have nothing for you. You have back pain, go see your primary care physician. And this is how it's misdiagnosed or underdiagnosed. And this is how a patient like Haley is sort of stuck in this roller coaster for years and years before, quite frankly, in listening to her speak, she sort of diagnosed herself based on her family history and based on being vigilant and trying to figure out, well, I know I'm not crazy. I know something is wrong. And I understand that all these doctors are saying one thing or another, but and that's how it goes. Now I have two PAs who help me in the clinic and see patients. And I say this to them all the time. A young patient with SI joint pain, sacroiliac joint pain, or low back pain and stiffness that hasn't gotten better with a short course of physical therapy and an anti-inflammatory medication, and with a normal x-ray and a normal MRI, then those patients need to go see one of our rheumatologists. And we do have a rheumatologist in our group, and we have excellent rheumatologists in the community that I refer young patients to because if it doesn't make sense, if it doesn't fit into all the other things, then we got to look elsewhere. And unfortunately, it's rheumatologists who end up making the diagnosis of ankylosing spondylitis in young patients without the pathognomonic or without the typical X-ray or MRI findings. Now, thankfully, a lot of the patients with ankylosing spondylitis are either asymptomatic, meaning they don't have symptoms, or they have mild symptoms that allow them to continue normal activities of daily living and normal lifestyles and gainful employment without having any dysfunction as a result of it. But for the percentage that do have pain, then it can be fairly debilitating if not diagnosed early and treated appropriately. Now, the vast majority of the treatment of ankylosing spondylitis is medical treatment. If we look at the literature, it does state that patients, especially with neck issues, with stiff necks or chin to chest deformities as a result of the stiff necks, then those patients, an option is replacing those discs, meaning performing artificial disc replacements. But these are very risky procedures. And I can tell you that in my 12 years of practice, I have yet to perform a single artificial disc replacement on a patient with ankylosing spondylitis. The patients that I see with ankylosing spondylitis that I end up performing surgeries on are those that have fractures as a result of the ankylosing spondylitis. And if you think about it, the reason that the human body is really one of the most efficient structures ever, I tell the patients this all the time, that the reason we have all these discs and the reason all these discs have some motion is because we need it. If we didn't need it, then we would have evolved into beings without disc replacements, without discs that move, or we would have been created without discs that move, depending on what you believe in. Now, but the patients who have late stage ankylosing spondylitis and stiff spines, Dr. DeSilva touched upon the fact that although they're fused, it is not a good fusion. It's actually fairly brittle bone, and even minor trauma can cause a fracture through the whole spine, the front and the back. And such fractures in a patient with ankylosing spondylitis are unstable. What I mean by that is they're unstable, meaning the spine, the column can move. And if the column moves, it can injure the spinal cord or spinal nerves. Now, to add insult to injury, these are undiagnosed or poorly diagnosed fractures in ankylosing spondylitis patients are poorly diagnosed and generally present late after the patient has started to develop some neurologic deficits. So as an orthopedic spine surgeon on call, if the ER calls me and says, oh, I have this patient with back pain, I looked at the x-rays, everything looked fine, we're going to send him on and have him follow up in the office, I always look at the x-rays. I don't take their word to be 100% accurate. I always have to look at the x-rays. And if those x-rays show ankylosing spondylitis, then I will tell the emergency room physician to perform a CT scan or an MRI of the lumbar spine or the thoracic spine, wherever the pain is, to rule out a fracture through that fusion mass, through that ankylosing spondylitis. And if there is indeed a fracture there, then the treatment is surgical. You have to stabilize the spine above and below that fracture so that there's no subluxation at that level. Because if you do have a subluxation in the thoracic spine in the patient with ankylosing spondylitis, then there is a high risk of neurologic injury or even paralysis.
Well, and on that note, I guess along those lines, when it comes to, you were talking about, stabilizing the spine with surgery. So for patients who have had this type of diagnosis, and maybe they have had, a little bit of this fusion starting to happen, what types of things should they be prepared for? Are there any things that they can preemptively do so that, hopefully they aren't going to have to progress to this point of having to have additional surgery to stabilize the spine?
Right. And I think Dr. DeSilva touched on that. I think number one is to continue to have motion. I think physical therapy, stretching exercises, keeping the motion at those disc spaces going actually does decrease the likelihood of having a stiff spine. The fusion across the disc space, that bamboo spine, is actually calcification and bony formation of the outer segments of the disc. And so if you can keep that moving, for a fusion, you need stabilization. You need sort of things to stand still. If you keep it from standing still, then that can decrease it. Now, unfortunately, it doesn't stop it completely. We sort of need the help of anti-inflammatory medications, steroids, or DMARDs, which Dr. DeSilva touched upon. Now, the stabilization is actually just for patients who have had fractures as a result of having a stiff spine. And unfortunately, I see probably one every year or two, and I saw it a lot more when I was in training at Ohio State University Medical Center, where patients would get transferred in from all over the state, and it was patients who were underdiagnosed or misdiagnosed with ankylosing spondylitis and misdiagnosed fractures.
So this question, it was initially directed to Haley. I think it's actually going to be I'd like to have all of our doctors chime in as well, because both of you have said, you get so many patients who say, I'm not crazy. So Haley, one of the questions that kind of came out to you is, for people who are listening and dealing with this, how did this impact your mental health and what can be done about it? I'd love to get your perspective as well as a doctor's perspective in terms of, what happens when those patients come to you, and are there support services, or sometimes it's just getting the diagnosis validation enough.
Yeah, so I can definitely share my personal experience. Obviously, it's not the same for everyone, but I think traditionally, one of the comorbidities of ankylosing spondylitis is clinical depression. And the reason for that is pretty simple. Chronic pain, as the doctors have discussed, and I've hinted at, is very emotionally taxing and actually exhausting, especially when your immune system is constantly fighting itself. And I think there's an element of the disease that people need to focus on, whereas in comparison to other forms of arthritis, which typically affects individuals in the second half of their life, ankylosing spondylitis is unique in that it usually affects individuals sometimes as early as their teens, definitely by 20s or 30s. So this is the peak of someone's career, someone's personal lives. For me, it really made an impact. My symptoms got significantly worse days after my wedding. I was supposed to start practicing law and had to stop that plan as well to get proper treatment and get myself to where I am now. And I think it's very isolating in some regards too, because a lot of your peers when you're this age are most of the time not dealing with health issues. So they don't really know what to say or what it feels like to be in pain, or what it feels like to get a scary diagnosis such as ankylosing spondylitis. Whereas if I was in my 60s or 70s, I would think that more of my peers would have gone through some scary health diagnoses. So I think that is hard. Dr. DeSilva mentioned support groups. I'm a part of a large Facebook support group that actually focuses on the no starch diet. It's an international support group. And those individuals are complete strangers to me, and some of them have helped me more than some of my closest friends or family, just because they get it and they understand what it's like, and we really lift each other up. I think you have to be careful about support groups, at least in my experience, as some are extremely negative and very scary. And while it's important to be honest, hearing about all like the progression and the scary stuff and how bad you are every day doesn't really help anyone. So I would say that support group in particular is very positive, and I've really appreciated having that.
And Dr. DeSilva or Dr. Darwish, sorry, are there particular, Dr. DeSilva or Dr. Darwish, are there particular resources that you found that are also helpful to your patients when they start going through this or in connection with their diagnosis?
Yeah, so I mean, I don't have any specific resources itself. I think just making sure that you have an open communication with your provider, right? So I can tell kind of with my patients, especially the ones that I end up seeing, because they'll end up seeing me for years at a time. It's not kind of like a one appointment and then, okay, bye, you have this disease, that's it, right? A lot of the medications, and even if it's just therapy that we're doing, we're keeping close follow-up. And so a lot of times I can pick up when they're just not, they're in a rut, there's a lot of other social stressors. So being able to manage stress in general, I mean, for any of us, it's important, right? But particularly when you have an autoimmune disease, these stressful events can be a trigger for flaring your disease. And so being mindful and getting kind of learning like coping strategies and everything is important, as well as having that open conversation with your providers, as well as family members and friends, coworkers, if needed, about, hey, you know what, I'm just not having a good day. My, disease is flaring, or whatever you want to, you choose to divulge, but just having that open conversation and, knowing that it's okay to not feel okay sometimes. And it's hard, but having that conversation. And if it is getting to the point where you are feeling clinically depressed, knowing when and who to reach out to is important.
And Dr. Darwish, one question for you, and again, this kind of, and then Haley, I'd love for you to follow up as well. You said that you do see a lot of people in the context of their athletic activities, that's how they wind up getting towards your office. Are there any signs that someone who is engaged in athletics at a young age, who's, experiencing this type of pain, should just be watching out for or mindful of, that might indicate, well, maybe this is something that's a little bit more serious and I should reach out to a doctor like you or to Dr. DeSilva to try to get some additional insight?
Sure. I think that I do see a lot of young athletes and some college athletes and some high school athletes with low back pain. And the thing for these patients and for really clinicians to watch out for is if their condition is not following the normal natural history of the diagnosis that we made. So if I see somebody and I diagnose them with a lumbar strain, well, a lumbar strain past 6 weeks is no longer a lumbar strain. There is some cause to that back pain. There is some cause to that neck pain. And at that point, we sort of need to go one step further and either obtain the diagnostic study to show what's going on, or the test usually ordered by a rheumatologist to check and see what is causing the back pain. Now, the answer to the previous question on what to do with in terms of a network of patients with the same condition that can help. In surgery, our relationships with the patient is very short. It is very limited, and so with us, we realize that any pain or any dysfunction or any change in lifestyle, especially in a young patient, can cause anxiety and can cause depression. So we have a psychologist that we refer patients to if there is any sign of anxiety or depression. But really, I think the most important thing is to sit down with the patient and to explain to them the diagnosis and how things may or may not go in the future. I think the thing that causes the most anxiety in my patients, at least, or in my experience, is the unknown. It's to have pain and not know what's causing it and where we're going from here. And if a patient has information, then they're sort of in control of their treatment. They sort of understand what's happening to them. And that definitely brings down the anxiety and certainly brings down the depression or any feeling of depression, in that if they understand that this is a temporary thing and that we're heading in the right direction, it sort of provides hope and then decreases the likelihood of that happening. Now, again, with me, they're very short relationships, but at least we sit down with the patients and we try to make the diagnosis. And once that diagnosis is made, we spend time with the patient to help them understand what it is and where we go from here.
And Haley, how did you find that in terms of trying to adjust to this new normal? And when you first started experiencing some of these symptoms, I think you did notice some of them when you were playing sports, but then once you did finally get the diagnosis and now you're looking at, you have to change your diet, you have to change your lifestyle, you have, I mean, that's really in and of itself a big upheaval that you have to deal with. So, what tips and techniques could you offer to people in terms of how they might be able to, help handle this type of thing?
Yeah, that's a great question. Can everyone hear me? Okay, yeah. So I think first off, it's really hard, just to put it simply, and it's very daunting. I think a lot of patients with ankylosing spondylitis choose not to sometimes be as extreme with their dietary changes because it is very difficult. But I would say that pain is a great motivator. There's a reason why we use it when interrogating people. So I think that for me, it was not a kind of a no-brainer. It's a little bit different than a diet for weight loss or aesthetic purposes. At least that didn't motivate me in the past, but maybe I'm by myself there. But when I was in pain and unable to sleep throughout the night, which in my mind is a form of torture in itself when you're getting 1 to 2 hours of sleep. And I think any new mom would agree with me there. And then you have the chronic pain element where I wasn't practicing law that I expected to. I was unable to do anything that I enjoyed. I was willing to do, quite frankly, anything. And I actually was a vegetarian for a long time prior to making these dietary changes. And interestingly enough, my diet now consists mainly of, I would say, a cross between keto and a paleo diet. So it's a lot of whole meats, fish, and food, and whole foods. So leafy greens, really staying away from all starch, all sugar, even most fruit sugar. So really just berries and some low fruit sugar foods as well. So it's definitely been hard. I know I've made the suggestion to my dad to change his diet and he's a little bit more reluctant. But it's, there's no judgment. I think everyone does what they can to get through this disease. As we've all stated, one of the unfortunate facts of this disease is it's forever and it affects us from a very young age. So that statistic in and of itself, like Dr. Darwish was insinuating, is very hard and causes anxiety, because realizing that this is forever for maybe 80 years, maybe longer for some patients, that's very overwhelming. It's not like, oh, I'll be better next year or in a few years. So I think doing all that you can, whether it's moving every day or changing your diet, is really important for your mental health and your physical health.
And what sort of things can people do if you maybe this isn't a disease that you yourself are experiencing, but you're a friend, a family member, a spouse, a neighbor? What are some of the things that people can do to try to be helpful and supportive? And what are some of the things that you would put on the please don't do this list, in terms of just, trying to make sure that that we're showing the appropriate empathy for people who are going through this?
Yeah, I think one of the difficult things about this disease is it's an invisible disease, meaning that it's hard to see when someone's suffering, especially if someone hides their pain very well and is early on in the disease. So later on, Dr. Darwish mentioned bamboo spine. That's when your whole spine fuses, and usually there's kyphosis, so like a bent over position in extreme situations. But individuals like I have been suffering from this disease for at least a decade and have permanent damage in my right SI joint, but nobody would really know that just looking at me, because I seem very young, I seem and walk and act normal. So I think just because someone looks okay doesn't mean that they are okay. And of course, that is really important for that person to choose to divulge their diagnosis. So that's the first step. But I think understanding that another aspect of the disease is that it changes every single day. So I have periods where I have, like I said, very low pain, and I'm so grateful for that. But then sometimes my pain can increase literally overnight within the drop of a hat, and I have no control over that. So it's not because I changed my diet. Sometimes it's weather, cold, rainy weather, which we've been experiencing a lot lately. Stress is sometimes a cause of a flare. So I think understanding that too is sometimes hard for people. Just because Haley was okay yesterday doesn't mean that she's going to be okay tomorrow, and really supporting her during those tough times when she's not okay is really important. And then to answer your question about what not to say, I think saying things like, blanket statements like, you had this, you were dealt these cards because you're a tough person, or God only gives you what you can handle. I think those are meant sincerely, and I appreciate that. But coming from someone who's dealing with something hard, I think they don't love to hear that, because nobody wants to have to deal with something that is forever and is painful every single day. So I think just saying things like, how can I help you today? How are you doing? I have a friend who checks up on me every few days, and she goes, how is your pain today? And it's really just as simple as that. And then, when I'm really bad, just checking in more and seeing what you can do to help. During my worst period, when I was flaring in this fall, I couldn't even bend down to pick up something off the ground. And so that's very humbling, and it's embarrassing sometimes too. So trying to be there for your friend or family member is really important.
One question that we did get is for our doctors who are on the line, how can people find you if they would like to reach out to you and, whether it's for a consult or, to make a referral for a friend or something along those lines?
So I'll go first. So I'm a rheumatologist actually at Edward Hospital in Naperville. I have offices in Naperville and Plainfield. You can find me if you go to, I think it's eehealth.org. And when you go through like your physician, there's a way to look up physicians. And if you just type my name, DeSilva or Nisha DeSilva, it'll pop up. I also work with 2 other rheumatologists that are in our practice, but there are multiple other rheumatologists in the area, like Dr. Darwash mentioned, as well as, other groups in the area. And, if you wanted to find me specifically, that Edward Hospital website is where you can find my contact information, and the address and the number and everything's listed on there.
And how about for you, Dr. Darwish?
So I practice at Hinsdale Orthopedics in Hinsdale, Illinois. I have offices in Hinsdale as well as Western Springs and Elmhurst. It's easy to find me online by just Googling my name, Ashraf Darwish, or by Googling Hinsdale Orthopedics or going to hinsdaleorthopedics.com. I'm in clinic 2.5 days a week and in surgery 2.5 days a week.
Okay, fantastic. Well, I know we're getting to the end of our hour, and I do want to just thank everybody, each of our panelists who have shared their time with us today, their stories and their information. And obviously, while this is just an introductory webinar, obviously this 1 hour can't possibly go through the full depth of not only treatment, but experiences that people like Haley are going through on a day-to-day basis. So if you do have any additional questions or need additional follow-up, please do feel free to reach out to my district office. You can always email me at Mazzochi at ilhousegop.org. You can also call the Westmont office, and all of our information you can find at ilga.gov. Just go to ilga.gov, click on members, and you can find my name and all of my contact information. One of the things, though, that I do want to say, just from Haley, all of the comments and questions that we got, we couldn't necessarily get to them all, but I think that there is a common theme to all of them. So I will give you the ultimate last word. And it's basically, thank you so, so much for sharing your story and what it is that you have to live with on a day-to-day basis. And if there's anything that you could, share to say, here's how you've dealt with it. Here is what you've done to try to make, a boring diet interesting, exercises, that type of thing. You mentioned the name, you mentioned that there is a Facebook group. What's the name of that Facebook group, so that people can try to reach out and, and again, make these connections, use some of the tricks and the tools that you've adopted, so that you can, again, make this something where you're not just enduring, you're really actually living.
Yeah, thank you so much, Representative Mazzochi. Again, I really appreciate you pushing this through and making a huge difference, not only in my life, but a lot of our fellow Illinois sufferers out there. I think that it's really simple. I think first and foremost, advocating for yourself, especially if you're a woman or a Black, Indigenous person of color, is really, really important, especially with this disease. Because as we've already stated, it is traditionally thought to be a primarily Caucasian male disease, but now we're finding out that's no longer the case. So if you really feel like something's wrong, as both of the doctors on this call have stated, if it's going on for a long period of time, you're not crazy. And I think the getting past medical gaslighting, or whatever you want to call it, is sometimes difficult, but being really true to yourself is important. In terms of what's helped me, I think I felt this fall that I lost control of my life and my body. And at 31 years old, that's a very scary reality, as I'm sure everyone listening can imagine. But one of the ways I got control back was really changing my diet and exercising every day and committing to that, and seeing how fast my C-reactive protein levels fell within a matter of several weeks. Both my primary care physician and rheumatologist were shocked at the success that I had just through dietary changes. And then finally, the support group has been instrumental with for my mental health. It's called the Low No Starch Diet Ankylosing Spondylitis group on Facebook. It's an international group, so that's kind of cool because you have individuals from all over the world helping each other. And everyone looks different and comes from different backgrounds. So that just shows that, once again, that the disease does not affect one group of people. But I think really being honest and open about my disease, at first it was really hard and embarrassing to say, you know, I have I look like I'm 31, but I have the body of an 80-year-old. That can be hard for some people. But I think being open and honest with your friends and family is one of the only ways that they can truly support you. And if they say something like, you know, just be positive or something that upsets you, really telling them what they can do to help you is going to be instrumental in your success, because you can't do it alone.
Thank you so much, Haley. We really appreciate that. And again, thank you to Dr. Nisha DeSilva, to Haley, and also to Dr. Ashraf Darwish. Thank you to all of our panelists for sharing your time, sharing your stories, and to all of our attendees, both today as well as in the future. This webinar will be on our website, and we'll be sharing it again on Facebook. We hope that you found this informative, and if there are other issues that you would like us to also talk about that can try to help you or members of our community, please do reach out to my office. So thank you so much, everyone. Have a wonderful evening.